So today I'll be talking about the management of the inflammatory bowel disease. Some recent updates. There are thousands of the clinical research which is going on this topic. So I'll be covering some of them, which includes the natural history and prevention of inflammatory bowel disease and the current emerging therapies in non-biologic category, the small molecules, and also the emerging therapies in the biologics and the disease monitoring tools, and as well as the disease-related outcome and the quality of life in the inflammatory bowel disease. So regarding the epidemiology of the disease, this is one of the landmark study called GEMS project, which has evaluated the genetic, environmental, and microbial determinants of the Crohn's disease. And this particular study has included around 5,122 individuals who are the first degree relative of the patient with the Crohn's disease and followed up for the 15 years. And it assessed the different environmental microbial determinants of the Crohn's disease. So here are the outcome of this study. In the first outcome, that the offspring who are exposed to the parents diagnosed with the Crohn's disease during the perinatal period had the increased future incidence of the Crohn's disease with a hazard ratio of 4.7-fold. And similarly, it is true in the multiplex family scenario in which more than one first degree relatives are affected with the Crohn's disease. They are likely to have the Crohn's disease in the future with a hazard ratio of 3.2 folds. There are certain uh, constituents, for instance, the alcohol, aspartate, and docosahexaenic acid. These are the components. This docosahexaenic acid is present in the canola oil. Alcohol and aspartame is the one of the artificial sweetener. They were found to be associated with the higher incidence of Crohn's disease among the individuals who are related to the Crohn's disease patients. There are certain serum metabolites that are related to the gut barrier function and inflammation were also found predictive to the Crohn's disease, which include the enrichment of the sphingomyelin and aspartate and the depletion of the isoleucine, leucine, and valine. They are associated with the incidence of the disease. So these are the two studies which compared the different dietary constituents that can predispose to the Crohn's. So this first study included 214 patients, Hispanic patients with inflammatory bowel disease, and followed for 1.2 years. And 33% of these patients had the flares. And the study has concluded that the diet which is rich in the starchy vegetable and the tropical fruits, they are associated with the lower incidence of the clinical activity, fecal calprotectin, and flares. So in this second study, you can see in this particular diagram, the red line, which is at the top, it shows that the individuals who are consuming the protein, which is less than 25 grams. So those who are consuming the less protein, the flare-free survival were more in these individuals compared to those who were consuming the more protein. So there are certain emerging therapies in the non-biologic categories. Some of them are already known. Few of them are new in this category, relatively new in this category. And one of them, the molecule which is called upadacitinib, it is a JAK1 inhibitor, and it showed a promising result in the different trials. So this is one of the trial, which is the UXL trial, in which the patients were inducted who were not previously exposed to the biologic therapy, and those in UXC trial, the patient were inducted who were previously exposed to the biologic therapy. And during the induction phase, this green part is the induction phase, in which the 45 milligram of this molecule was given for the 12 weeks. And once the clinical remission is achieved in the 12 weeks, they were subjected to the lower dosage in the subsequent trial, which is called Endure trial. And here the patients were categorized further into three categories: 30 milligram, 15 milligram, and placebo. So here is the outcome of this result with this upadacitinib. You can see that the endoscopic response is significantly higher in the first 12 weeks during the induction phase. And after the induction, once it is placed to the maintenance phase with a 15 milligram and 30 milligram dosage, during the maintenance phase, the response was also very well maintained up to the 52 weeks of the study. And those patients, 50% of the patient achieved the clinical remission in the induction phase, and those who did not achieve the induction, they were given further 12 weeks of the induction therapy, and half of them again achieved the remission with the extension of the induction phase, and they are well maintained afterwards. So this is the promising result with this particular molecule.
When you say remission, please tell them what kind of remission would go.
Yeah, so they are categorized into the different remission. For instance, those who have the previous biologic failure, it includes the endoscopic remission, in which 50% of 52% of the patient achieve the endoscopic remission here in the induction phase. And here also the endoscopic remission was observed in around 36% of the patient. So during this induction phase. And the same. Yeah. This one, man?
Yeah.
Yeah. So there are the different categories. For instance, the clinical response, which is measured by the number of the stool, the blood in the stool, and also the endoscopic response, and as well as clinical remission, endoscopic response, and the histological remissions. So the clinical response were higher. However, if we go downwards to the endoscopic response, so they are relatively lower in this particular category.
Versus there's 3.
Yes, ma'am. So this is the data on the fistulizing Crohn's disease with this particular molecule. And here the 143 patients were included who have the fistula or the anal fissure. And the endpoint of the treatment were the external closure of the fistula or the complete resolution of the draining or more than 50% resolution of the draining. So again, this orange bar is showing the induction phase, and this blue is showing the maintenance phase. And you can see that the external closure of fistula was around 20.8% in the induction phase, and the complete resolution of draining was around 47% in this induction phase. And similarly, it is maintained in the maintenance phase also. However, the 15 milligram performed slightly better in this particular area, probably because of the number of the patient which were included. If the large number of the patient will be included, then probably the 30 milligram will be performing better. So this particular study has evaluated the efficacy of upadacitinib with the is effective in patient who has the previous tofacitinib experience. And here you can see that the clinical remission and endoscopic remission at week 16 at 6 months, it was in 85% in biological naive patient and 71% in those patients who were previously exposed to the biologics, 1 to 2 biologics, and it is 83% those who were exposed to the 3 to 4 biologics. So endoscopic healing was slightly lower in the particularly those who were previously exposed to the 3 to 4 biologics. And the similar clinical response, clinical remission, they were significantly achieved at the week 2, week 4, and week 8 with this particular molecule in those patients who was previously exposed to the tofacitinib. So this is one of the open label trial, and it is a single center case series in which they have included those difficult to treat patients who had the acute severe ulcerative colitis. And in this particular group, they have given the higher dose of upadacitinib, which is 30 milligram, and they have demonstrated that the colectomy-free survival was significantly higher to those patients who received this intensive therapy of this particular drug. However, this need a prospective trial and the validation for the optimal dosage and the duration of the therapy. Facetanib and ustekinumab has the similar effectiveness in the ulcerative colitis after the anti-TNF failure. So here, this is the head-to-head trial between these two molecules, which is the ustekinumab and tofacitinib. And the result came out to be that the corticosteroid-free remission was 37.8% in TOFA group compared to 35.6% in the ustekinumab group. So these two results are comparable, and the factors which are associated with no corticosteroid-free remission at week 16 in ustekinumab group are the male gender, prior biologic therapy, prior use of tofacitinib, and primary failure of more than one biologics. So this is the trial which has compared head-to-head the tofacitinib and the vedolizumab. Here in this particular diagram, this red bar is the vedolizumab and this blue is the tofacitinib. So you can see that the tofacitinib has performed well in all these responses, which include the steroid-free clinical remission, the endoscopic response, and the clinical symptoms like arthralgia, biochemical response, and the hospitalization. In the hospitalization, the vedolizumab performed well, but most of the cases, the tofacitinib has performed well. So tofacitinib was associated with higher odd ratio of the steroid-free clinical remission and the endoscopic remission at week 52 compared to the vedolizumab. So this is another molecule which is the S1P modulator, receptor modulator, ozanimod. And in this particular trial, during the induction phase, this is the Mayo endoscopic score of the disease activity has reduced from 2.5 to 1.0, and this Mayo score is maintained equal to or less than 1 during the maintenance phase also. So this particular drug is also showing the promising results. So there are concern about the safety of these medicines because there were reports regarding the bradycardia, macular edema, and the major cardiovascular events. So this study was conducted and it showed that 81% of the patient had the minor side effects, which includes the nasopharyngitis, lymphopenia, and anemia. However, 6% of the patient led to the serious side effects and requiring the discontinuation of the therapy. So this particular medication was also well tolerated. So this is the another molecule which is the S1P modulator in this group, and it has shown that and both of these trial has included the moderate to severe active ulcerative colitis, and they have demonstrated that the significant corticosteroid-free clinical remission, endoscopic improvement, and week 52. And this another trial also showed that the clinical endoscopic remission were significant at week 52 among those who are the week 12 responders. And this is the safety profile of this particular medicine, and the side effect profile is acceptable and comparable to the placebo group. So there are some emerging biologic therapies also. These are the biologic therapies which are already known, which include infliximab, adalimumab, vedolizumab, and ustekinumab. These two are relatively new in this group, which is mirikizumab and the anti-TNF like ligand 1A. So this particular study has evaluated the mirikizumab as an effective strategy for the induction and maintenance in ulcerative colitis, regardless of the prior exposure to the therapy. And in this induction phase, Lucent 1, and as well as in the maintenance phase, it revealed that regardless of the number and type of the prior advanced therapies, mirikizumab has efficacious in both induction, was found to be efficacious in both induction and maintenance phase in terms of the clinical response, clinical remission, clinical response, and the endoscopic remission. And this is the extended mirikizumab induction for the non-responder with ulcerative colitis. And it showed that the extended induction therapy, like extended up to 24 weeks rather than 12 weeks, has also led to the development of the response. So this is another new molecule in this particular category, which is anti-TNF like ligand 1A. This is in the phase 2 trial, and this is mentioned as a coded name particularly here, and it is compared with a placebo, and the baseline characteristics are demonstrated in this particular chart, which shows that with the baseline characteristics are comparable between the placebo and this TL1A inhibitor group. And here it is the outcome of the result, which shows that the clinical remission, endoscopic improvement, and clinical response were promising with this particular molecule also. And they have evaluated a positive genetic-based diagnostic test, particularly in this diagram. And they have not mentioned the name of this genetic test yet. But those who were positive with this genetic test has shown that they have a better response compared to those who were negative. So there are certain known tools for the monitoring of the disease activities. One of them is the fecal calprotectin level, which is commonly used for the monitoring of disease activities. But there are certain other emerging tools. For instance, the intestinal ultrasound, which we also widely practice in our clinic. This particular study has showed that the intestinal ultrasound predicting the corticosteroid failure in the patient with acute severe ulcerative colitis. So what they did, they measured the bowel wall thickness and the Doppler signal on the first day of the presentation, and then they measured after 3 days at day three. And they demonstrated that if there is an absence of the bowel, the Doppler signal at day three, and the thickness has reduced, so the steroid, the response of a steroid is very good in this particular group. However, those in which the bowel wall thickness is reduced less than 1.1 millimeter, and there is persistence of the Doppler signal, so the response of the steroid therapy in this particular group is not very well, with the higher area under receiver operator curve of 0.9 showing higher specificity and sensitivity. So this is the example from our clinic. So here you can see the terminal ileum, the wall appeared thickened here. And when we correlated it with the endoscopic finding, you can see that there are the diffuse ulceration in the circumferential ulceration in the terminal ileum. And this is the ultrasound image of the cecum, in which the wall is significantly thickened, appeared thickened. And when we go into the endoscopic examination, we found these ulcerated area in the cecum. So this is one of a very promising tool for the monitoring of the disease and as well as the prediction of the disease. Fecal calprotectin is a very well-known monitoring tool uh, for the inflammation in the colon. However, this particular study has assessed the inflammation of the small bowel using the fecal calprotectin in those patients who had the ileostomy. And here it is found that this is a predictor of inflammation of a small bowel also, and showing the area under receiver operator curve of 0.9 with a high sensitivity and specificity as it do for the colonic inflammation. So there are some future glimpses for this in the IBD. So with including the incorporating the artificial intelligence in the IBD care. So this particular study, the number one, is performed in the Korea, in which they have asked the patient to take the picture of the stool before they undergo the endoscopic examination. And they have correlated these picture of the stool with the endoscopic finding, and they found a good correlation. And the another promising tool is the passive touchless monitoring that collects the data during the sleep, breathing pattern, and the gait pattern, like a rapid breathing and the disturbed sleep and the shortened gait. They were found associated with the uh, can predict the flare of the disease. And also the computer quantification of the ulcer surface area. So there are certain studies which are doing, rather than the subjective quantification, they give the data, that videoscopic data, to the computer, and it calculates the total surface area of the ulcer, and it has a good correlation with the disease activity. So there are certain surgical input in this in the management of IBD also, particularly in this group, in which they compared those patients who received anti-TNF therapy to those who has undergone ileocecal resection upfront prior to the anti-TNF therapy. And what they noticed, that the adverse long-term outcome was 33% lower in those patients who received the ileocolonic resection compared to those and who received the anti-TNF therapy. And these adverse clinical outcomes were the hospitalization, systemic corticosteroid therapy, and the Crohn's disease related surgery. All these outcomes were lower in those in the group who received the ileocolonic resection upfront compared to those who received the anti-TNF therapy. So this is one of the anastomosis technique after the resection of the diseased bowel, and this is called Kono S anastomosis, which is a hand-sewn anti-mesenteric functional end-to-end anastomosis, in which the nervation and the blood supply was tried to preserve. The surgeon better can explain this anastomosis. However, this study has included 119 Crohn's disease patients, and they found that the endoscopic recurrence with this particular anastomosis were lower as compared to the conventional side-to-side anastomosis. And the clinical recurrence was also lower in this particular anastomosis type. So the quality of life during the IBD patient, so sexual dysfunction is a known factor that these patients suffer. And this particular study has evaluated the sexual dysfunction and found out that the sexual dysfunction score did not correlate with the biomarker or the inflammation or the inflammation in the endoscopy. Rather, it is correlated with the depression and disability. And as the patient improves clinically with the biologic therapy, the sexual function also improves in these patients. So there were questions about the safety during the pregnancy, the maternal and fetal outcome for these molecules, which is the vedolizumab and the ustekinumab. And this particular study has assessed this safety profile. And they found out that the ustekinumab level was stable throughout the pregnancy, and vedolizumab level decreased in from first trimester to third trimester. But there is no increase in the activity of the inflammatory bowel disease in these patients. So there was no difference in the adverse maternal and fetal outcome between these two molecules. So it has concluded that the routine drug level monitoring and dose changes probably unnecessary during the pregnancy. So what are the new and notable? So there are new small molecules, particularly like the upadacitinib, are effective across the range of the indications, which include the induction, maintenance, and the fistulizing disease. And there are promising data which is coming from IL-23 and TL1A, which need further trials in terms of the randomized control trials and validation of the new monitoring tool. For instance, the bowel wall thickness on the ultrasound and the artificial intelligence need further validation in the clinical trial, and it seems very promising. And several trials looking at the surgical treatment, like the type of the anastomosis and upfront surgery rather than the medical therapy. They are the new and notable things in the current era, and there are the thousands of the studies which are going on these topics. Thank you.